Top Med Talk.
Today's Top Med Talk is a two-part piece. This is part one of two. Enjoy.
Hi, I'm Monty Mythen, and welcome back to EBPOM USA live from Chicago. So, an enormous pleasure to be co-hosting this meeting, and a very great pleasure to be introducing Angela Bader. Welcome.
Thank you, Monty. So happy to be here.
Angela, so you're famous for your perioperative work, and as I understand, you have some new positions at Brigham and Women's, which I think even Brigham and Women's has had a name change relatively recently to acknowledge more of the Harvard associated with it. So, can you give us your full current title?
Okay, Brigham has now been combined with Mass General, and so we are now all under the name of Mass General Brigham at Harvard Medical School. I am the founding director of the Weiner Center for Preoperative Evaluation, which I worked with some very great donors to establish. And also, as you know, Monty, because you've been on our board, and we thank you for that, the founding president of the Society for Perioperative Assessment and Quality Improvement. And now I am on the core faculty of the Center for Surgery and Public Health at Brigham and Women's Hospital, which is a conjoined effort of Harvard Medical School, Harvard Public Health, and Brigham and Women's Hospital, actually through the Department of Surgery. So I think my main work now is actually, interestingly enough, being done through this effort, which was established through the Department of Surgery. And what I love about it is because the Department of Surgery, I'm also, interestingly enough, I think I'm the only anesthesiologist that's on core faculty there. I have recruited other anesthesiologists to work in our group, but as you know, Monty, the number of anesthesiologists that really understand and have great interest in perioperative medicine, I hope is increasing. And I know some of us have fellowships, as you do and I do, but it's a small number overall. And I think part of the reason I'm a legend is maybe nobody else wants my job. No, I'm happy because,
I'm interested.
As you know, there are a lot of us, and you're a legend as well, although, for many, many more noble reasons than me. But I'm really I think we really have to encourage people to develop an interest in this as a separate area. And that's why I think this area of perioperative medicine is new, as we discussed in our last session. And we need to really include it more in our training programs and as a ongoing interest, so our faculty perceive it as a credible area. I think one of the reasons was that I took something that was largely run by nursing as a system type of clinic and made it academic, and I think it was the shift from saying this isn't just a clinic that the hospital runs. Perioperative medicine is actually an academic specialty with evidence-based protocols and outcomes. And I think that's honestly the shift I've seen over the past 20 years. And probably, and I'm kind of only half joking here, why I'm now the second woman professor at Harvard, because it's an innovative thing to have worked in. And I think that's honestly a huge change. And I'm hoping now, this is the second year of our perioperative fellowship. And this is new for us. I know you and Saul at Duke have had perioperative fellows for a while, but I think we need more and more people to understand the importance of this as a specialty.
And your lecture you did for us, Angela, really deals with one of the drivers for the need for the more rapid adoption of perioperative medicine, and that is the great news that our population in the well-resourced world is aging much more successfully, but with that comes polypharmacy, multi-morbidity, and very great expectations, and sometimes expectations that may not be fully explained about the wonders of surgical interventions compared to alternative approaches in the particularly frail elderly patient. And your pre-record lecture, for the people who haven't watched it, it's another great lecture from Angela about frailty, brain health, and perioperative cognitive dysfunction. And within that, you tease apart, the difference between frailty, POCD, delirium, etc., and give us some challenges in there, which are also about the regular evaluation of the frail patient and the different components of that we'll come to in a second.
Yes.
But also the cost burden of not recognizing some very, very scary numbers in there about the additional costs of pressing on. Can you give us a sense of the numbers that you mentioned within your lecture?
Yeah. So the problem is, again, we focus on the day of surgery. And when we look at cancellations and delays and costs to the operating room budget, the problem is we're not talking about the total cost of the care episode. And I forgot to mention, I work with Michael Porter's group at Harvard Business School on value-based healthcare, and I've studied with him and published a few things. And so looking at this from a value-based perspective, looking at patient outcomes over cost, which is his definition of healthcare value, if you take a patient who is cognitively impaired or frail, and in the United States, you look at what the actual cost of their episode of care is and what our reimbursement is. For example, if somebody is very frail and has a certain type of surgery, it can cost us $70,000, and the Medicare reimbursement only goes from 23 to 27. So if you don't account for frailty in your decision-making, your optimization, and your discussions with the patient, even if you just look at this from a revenue perspective, sure, you didn't cancel the case, but you cost the health system $70,000 and you're only going to get reimbursed $27,000. And I'm not even talking about the clinical outcomes that could be deleterious for the patient, even if we just talk about the cost numbers. And I think one of the things we need to focus as we train people in perioperative medicine, I am a big component of value-based healthcare, and looking at it from, honestly, the way that Michael Porter's group looks at it, this is not rocket science. There are ways to calculate this. We've developed ways to do process mapping. So yes, it's very difficult to calculate cost, but if you don't, you could be losing a significant amount of money and you think you're doing a good job because yes, you did the case. So not only is it bad in terms of patient-centered outcomes, but in terms of healthcare costs, especially with an aging population, we're going to see more and more of these patients. The impact on cost, if we don't take this into account, is going to be tremendous. There's an estimate that the cost of postoperative delirium, we all worry about cardiac complications, and we don't focus on preventing postoperative delirium in the United States is $150 billion a year. One case of delirium postoperatively costs between $15,000 and $50,000, and it's estimated at minimum that 1/3 of that could be prevented. So if we paid attention even just to delirium, potentially we could save $50 billion in healthcare costs, and the impact on patient lives would be immense.
And so we're in the midst of a viral pandemic at the moment. But ironically, probably myself and Mike Grocott, one of the co-chairs of this meeting, had just travelled back from a global summit in Australia talking about the global pandemic of post-operative morbidity, i.e. the number of elderly patients coming through, which is fantastic, but the expectations and the healthcare costs, if we don't start to manage these, will completely overwhelm without COVID-19, which is a twist that we, we're not hoping would not come upon us at this stage. We've got to get a handle on this. We've got to obviously do the right thing and look after the elderly patient. We're all going there, we hope. But also we have to be realistic about the finances that relate to this. I'm going to bring in our next two guests, if I may, Angela, before we get into some of the fine print of your wonderful lecture. So if we could add our next two guests in, please. So returning to the EBPOM stage, We have Jeanna Blitz. Hi, Jeanna.
Hi.
I'm guessing you're in Durham, North Carolina. Is that correct?
I am. It's still bright and sunny down here.
When I used to love down there, the spring and the fall was just magical. That was the time to be there. Summer was winter, is the way I remember it. In other words, that's when you had to lock the doors and stay away from the heat and the sweat and the bugs. But spring and fall was just, like the perfect English summer that we very rarely see. So, Jeanna, you're on faculty at Duke University Medical Center now, correct?
Yes, I am. I'm an associate professor of anesthesiology. I'm currently the director of our preoperative anesthesia and surgical screening clinic at Duke. And I also am the director of our perioperative medicine fellowship.
And as part of, I know you know Angela, I believe you do, because one of the overlaps between the three of us is one of the overlaps between the three of us is the SPAQI, the organisation that Angela referred to. I think you're an active component of that organisation at the moment. Can you tell us a little bit more about that, Jeanna?
So I'm currently the vice president of SPAQI, of that society, and we focus both on perioperative medicine as well as quality improvement. We represent a multidisciplinary as well as interdisciplinary group. So we have internists, hospitalists, surgeons, other professions, as well as anesthesiologists who are included both in our governing body as well as in our society. And we also have nurse practitioners, CRNAs, and other specialties who are included. So it's a great multidisciplinary group, which I believe is part of what perioperative medicine entails.
Absolutely. And from your perspective, perioperative medicine is public health, population health as well, because I notice in Angela's title, the surgical centre and public health go together. I think we're all recognising the fact that in these conversations, it's a public health endeavour, perioperative medicine.
Oh, absolutely. I truly see so many times in my own practice from day to day how the opportunity to have a patient come and present themselves when they're looking to have a surgery might be the first window in a very long time to that patient and their healthcare for either reasons that relate to perceived stigma or bad experiences or other social related factors. And it really represents an opportunity to bring them back and to get them back onto a better trajectory in terms of their longitudinal healthcare.
Great. So now we're joined again. Great to see you again, Sarah Locke. How are you, Sarah?
Thank you.
Sarah, as I understand in your background, you were an attorney at one stage. Is that correct?
I am. Absolutely.
And now you have a role in the AARP. Is that correct?
Yes. So for people who are unfamiliar with it, AARP is a nonprofit, nonpartisan membership organization advocating on behalf of people 50 and older in the United States. And we're interested, of course, in that across the world. AARP's mission is to empower people to choose how they will live as they age. And a very important part of people's living well as they get older is their ability to do the things that they love and live independently. And of course, the ability to stay sharp as they age is absolutely critical to adults. And so AARP founded the Global Council on Brain Health. We are not a healthcare entity, so it's a great pleasure to join you all as you're discussing these issues. But we have partnered with many experts around the world to address the issues that impact people's brain health and their ability to stay sharp as they age. So the Global Council looked, starting last year, we met in Boston with experts from India and Australia, Asia, Europe, and the United States. We brought experts together to look at this issue of delirium and post-operative and perioperative cognitive decline. And we recently put out a report, and we actually call this the most common complication of surgery you've likely never heard of, because it was shocking to me to understand just how widespread this is, how much, as Angela was talking, how it costs the healthcare system billions in wasted dollars. And it's the perfect opportunity from where I sit at the intersection of policy and patient advocacy to drive down the cost while improving care. The idea that you can improve care and perhaps prevent this from happening at all for many patients is incredible. People don't know about it. And when we conducted this report to try to understand what the state of the science was around this issue, we conducted a survey of both healthcare providers and adults. And there is a huge mismatch in what people understand and what the healthcare system understands. And even though it's widely understood in the healthcare system that this is a common occurrence, they're not telling patients about this. It's not a risk that people are. So there's lots to be done here.
Absolutely. So Sarah, you suggested there that it's widely acknowledged within our profession that how common it is. But Angela, as part of your lecture and lectures you've given over the years, I think you've challenged us to say that perhaps we're underestimating how common it is, and you presented some data in your lecture about that. Could you remind us about how common it is?
So my concern is, I think all of this comes back to training. You know, I'm involved a lot at Harvard Medical School with the students, and it's incredible to me. You know, I went there, eons ago, and we haven't changed in terms of how we educate medical students about these issues. And I don't know, Jeanna, at Duke, maybe you're more advanced than us, but I talk to a lot of these medical students, and I often do work with them in research because they're not getting this education anywhere else in delirium, in what happens to geriatric patients undergoing stress. And it's very different, as we talked about earlier. I'm not talking about this from the concept of long-term geriatric care. I'm talking about taking one of these patients who maybe they're well managed by their primary care doctor or geriatrician and putting them under a stress like this. And we aren't educating people. And it has to start with the training programs. If we don't start training in the medical student years, in the resident years, and then reinforcing it in the faculty. For example, I'll give you, in America, as you know, most of you know, we have to take anesthesia boards. So I offered to give, and we have a lecture and curriculum. I said, well, I'd love to give to the students a lecture on these topics, shared decision-making, geriatrics. And they said, no, because we have limited time for these lectures and that's not on the boards. So, I feel like, and, I was kind of shocked, but, I think that's the heart of the problem is we don't, even if we acknowledge it, it is not being recognized as important.
I couldn't agree more. So I think that when we think back to the value-based care model that we're talking about and how this all feels like, and we understand this is the right thing to do, sometimes the greatest barrier to actually doing it is our discomfort with how to initiate that conversation with the patient, with their family, with our surgical colleagues, et cetera. And so something that I've been focused on in the most recent past, and I'd love to share a little about. So in my pre-op clinic, I have both an intern on the rotation as well as an anesthesiology resident. And so one of the things that we're working on is actually saying, hey, for every patient that comes in that's 65 and older, we are going to pause and we are going to have a goals of care conversation. And we want you to become comfortable with this over your 4 to 6 weeks on the rotation with me. We've created prompts and a template to use about how to ask permission to have a sensitive conversation, how to prepare them for the fact that these are the types of topics that we'd like to discuss. And so what we're working on now is working with our palliative care team, our geriatrics team in the POSH clinic, which is our senior health optimization clinic, as well as our surgical oncologists to scale this and expand this into actually a section of our electronic health record that tracks changes about what did the patient say on this date. And as more information came in and as they had time to process this information about their diagnosis and speak to their family members, how has their decision-making sort of changed? And when is it time to check back in along the way so that we can follow this patient from when they receive their diagnosis, when they speak to their surgeon, through when they're seeing us in our preoperative optimization clinic, forward to the operating room, the ICU, or the post-operative ward, etc. So I appreciate you giving me the opportunity to share that because Professor Weiner and I are often on the same page, as we know.
That's great, Jeanna. I'm really happy to hear that. Just to mention, one of the things that we're doing a lot of work on is something called the POST or the MOST, which is medical orders for life-sustaining treatment, which I'm sure, as Sarah knows, many geriatric patients are very interested in filling these out and making sure their caregivers understand what their wishes would be. And we just got some preliminary data that was incredibly disheartening to me, that in surgical patients that have a MOST, in Massachusetts, we call this a Massachusetts order, and it is an order, you're supposed to follow it, 85% of these are not discussed till the morning of surgery. I mean, that is horrifying to me. And it's very hard, and the problem is I cannot there's a disconnect because to discuss that before the day of surgery would take resources. And
yes,
there's a big lack of understanding of exactly what if you're not discussing a MOLT form till the morning of surgery and the patient's there and the IV's in and, and it's 85. And the other interesting thing in our data, 85% of the time it's done by the anesthesiologist on the day of surgery. So now, again, this is example of one institution. And I find this horrifying. Apparently not too many other people do, but at least, to do something about it. But again, I don't know, Jeanna, what is your experience at Duke with this, with those kind of discussions?
I mean, that's certainly something that we incorporate. And yes, oftentimes it comes down to our clinic having those patients and obtaining that documentation for sure.
Are you doing that ahead of time? That's yes. Great. That's great.
Mm-hmm. I think that the other place that my mind is going, and I know you've done some work on this, so I'm certainly following your lead, but it's been eye-opening to look at the percentage of patients in which there is a discordance between their expectations around what the surgery might do for them and what we think is reasonably expected in terms of patients who do have a discordance or a lack of clear expectations or understanding. And then how do we set up an intervention to try to help them?
So Jeanna, can I is that discussion about attitudes to end of life built into every preoperative evaluation? I mean, I was co-authored an editorial about this being the elephant in the room in the last few years, is that for some reason there's a reluctance, even though mortality is often there as part of the, let's talk about what could happen next. It's not routine to factor in an end-of-life discussion, if you see me.
So the answer would be yes and.
Yes.
For patients who are 65 and above, who are presenting for a surgery where there is a required hospitalization. So I cannot with certainty promise you that we're doing this before a colonoscopy or ECT therapy. So I can't say 100%, but our focus right now is on patients who are coming through our clinic, who are medically complex, have a frailty syndrome, cognitive frailty, et cetera, and are coming for a major surgery. And I should say are being seen by either myself, my fellow, or our residents. That's our target population right now. We hope to scale this beyond that, but that is what we've been tackling this past year.
So Sarah,
I would like to ask Sarah a question on.
Oh, good. Well, you can do, because I was going to ask her one. Go for it, Angela.
Sarah, so one of the obstacles that I face is, how can we get groups like yours involved in a way that will show our institutions that this is important? That patients do want this addressed, that they're not going to be afraid of a cognitive evaluation. And this has been a huge struggle for me. So this is the other reason I'm so thrilled to meet with you today, is I think that we need to partner with institutions like yours to get it across that this is really important. What can we do to do that?
Well, I am delighted to build a strategy with you all to try to address that. I will tell you that there are colleagues that we have started to have this conversation with and are trying to address it with CMS and other organizations that would have significant impact with institutions across the board. But I will just say, institutionally, you all are leaders in this space. But I would tell you that there are other leaders within your institutions who are working on these issues, and just bringing you all together would be a tremendous advantage, because we found in our work with the Global Council, neurologists, geriatricians, primary care physicians, all are coming at this from very different perspectives. And the lack of sort of continuity of care, it's really the primary care physician should be having conversations with the surgical candidate, you know, and the I'll just mention that at Harvard and Brigham, you must know Sharon Inouye, who's working in the geriatric field. And she was part of this panel, as Dan Blazer was from Duke. So there are numerous ways of us to get together and look at it. We're looking at it from a brain health perspective, but I think that sitting down and creating a strategy to say, look, we're talking billions here. And we're talking about devastation of people and families as a consequence. This is not a small problem. And it affects people for years. And it's frankly the message that, delirium sometimes resolves is true for some lucky patients, but for many, unfortunately, it's not. And their long-term consequences down the road, costing healthcare system. The billions you're talking about are billions in the emergency care world. We're talking long-term care, Medicaid programs. These costs go through our society. So I am thrilled that you have invited me kindly to join you, and would look for opportunity.
When we first started having these conversations, there was some concern from our other colleagues, especially, let's say, surgeons or other anesthesiologists. Don't scare the patient. They don't want to know this right before they're already overwhelmed. They don't necessarily want to think about a potential new diagnosis or something like that in this space. But what I will say is that, and again, I'm new at this. This has only been over the past year we've been exploring, but as we have these conversations, I've yet to find a patient or their family member who is scared or who is upset with us. Oftentimes they thank us, they call us days later and want to talk further. And they themselves see when they can't draw a clock, and the look on their family members' eyes when they realize this, I think is profound. So I do want to make that point that while there might be some reticence to engage in this over fear of scaring the patient, we ourselves have not seen that. I don't know, Professor Bader, have you seen that?
Yes. Oh, definitely. You know, I wanted to tell Sarah that I think, and I know Sharon Inouye's work because I'm in the same Harvard faculty as Sharon. The problem is they're leaving out surgery. You know, most of Sharon's work has not been done in preoperative patients. So she does absolutely wonderful things. And there is great work going on, and that's called the SAGE group that Sharon works in. But we haven't been brought in a multidisciplinary way, specifically in the perioperative space. So what I would really ask, and I don't know, you might regret that Monty has introduced us, I don't know, but how can we change this from the work that Sharon is doing, which is great, but very academic in nature, to bringing in your group specifically focused on that space, because that's what I don't see happening in that work. And then the second thing I just want to add, and there is actually some data on, Jeanna, what you talked about. Matt McAvoy published an article, I don't know if you're familiar with it, on what happens when you talk to these people. And what they found was none of them were made unnecessarily anxious. People that were low risk overestimated their risk, and people that were high risk underestimated their risk. So it was honestly, I think, a very profound and useful piece of data to find that out. So it worked both ways, both for the low risk patients and for the high risk. But Sarah, I really would ask you, to think about how can we bring the perioperative people into that space that, Sharon is working in.
Well, what a beautiful conversation.
We started a little bit with Lee Fleischer and the work that the Perioperative Brain Health Initiative, but I think we should broaden it a bit. And I would just want to say that I've got two sources of data that could be helpful, in that we did a general population survey of over 1,000 adults age 50 and older, and we asked them these kinds of questions, along with a healthcare provider survey of 556 different healthcare providers across the country. And the data there backs up that both the providers and the individuals who were experienced care thought these conversations would be helpful and necessary. Yeah. And 9 in 10 healthcare providers agreed that strategies to prevent delirium should be standard practice in hospitals, and that 80% said that delirium was a serious complication. Now, that's only delirium. And I know, Angela, you're looking at a broader swath.
No, but that's a very important component. It's important.
So I'm going to interrupt this wonderful conversation for a second to include our global audience.
Today's Top Med Talk was a 2-part piece. Don't forget, of course, on the way next, we have questions from the listening audience. That's part 2.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.